Dr. Onkar, is it working, the slides? Dr. Onkar? Yeah, the slides are changing now, no?
Okay.
Yeah, I think we're okay. So we'll just wait for 2-3 minutes. I think the faculty are yet to join in 2-3, Dr. Girish and Dr. Sahai. Huh?
Okay, okay, thank you.
Yeah, okay. We'll just wait for 5 minutes.
म्यूट अब म्यूट है मैं भेजूंगा एक लिंक को 15 लोग ज्वाइन किए
फिर पता चला था ना
अरे बच्चा कुछ नहीं होता है यार तुम एकदम से परेशान हो जाते हो चीजों के कौन देखेगा बच्चा
अरे रुको ना यार हटो तो यार हटो ऐसा सो के कोई
Mr. Prasad, just mute everybody. Huh? Only one who speaks can unmute themselves. Yeah. So Girish, have you joined? Dr. Sahai, you have joined, no?
Can you hear me?
Yeah, Dr. Samir Sahai, no?
Yes, ma'am. Yes.
Yeah, I can hear you. I'll just wait for a minute. Dr. Girish is yet to join. Then we'll start. Just 1 or 2 minutes. Dr. Girish, have you joined?
Yes, ma'am, I will join.
Okay, great. Yeah. So we'll just start now. Yeah. A very good morning to all of you. So, Dr. Onkar, you're ready, no?
Yes, ma'am.
Yeah. Okay. So, welcome to another Sunday morning session of Maharashtra Rheumatology Association Student Teacher Interface. As you know, this is a case presentation by a student of rheumatology. It could be a fellow or a DMB student. So, today we have Dr. Onkar Joshi. You're from Nair Hospital?
Sion Hospital,
Sion
ma'am.
Hospital.
Rheumatology fellow,
Yeah,
Sion Hospital.
rheumatology fellow at Sion Hospital. And your guide is Dr. Lalana, no?
Yes, ma'am.
Yeah, okay. So welcome to the program. Faculty for the case presentation today are Dr. Girish Kakade. He's a senior rheumatologist in Pune. He did his DNB clinical immunology and rheumatology from PD Hinduja Hospital, Mumbai. He's a very busy rheumatologist, so thank you for joining us today, Dr. Girish. Second faculty is Dr. Samir Sahai. He has graduated DNB post-graduation from Delhi in 2012, and it is EULA certification. He is practicing as a physician and rheumatologist in Pune and visits multiple hospitals, Ruby Hall Clinic, Inamdar Hospital, etc. He's got his own clinic and practice. He's also pursuing a MSc in rheumatology right now at the University of South Wales. So I'll hand over to you, Dr. Girish and Dr. Sahai, for the case presentation, and this will be followed by a guest lecture on a very interesting topic on the complement pathway by Dr. Lisa Rajshekhar, ma'am. So, Dr. Onkar, you can start your case.
Okay, ma'am. Thank you.
Yeah. Yeah, you can start, Dr. Onkar.
Yes, ma'am.
Yeah. We can't hear you. Hello?
Yes, ma'am.
Yeah.
Good morning, my respected teachers. I'm Dr. Onkar Joshi, Rheumatology Fellow at LTMMC Sion, Mumbai. Today, I'm going to present a case of a progressive muscle weakness. My patient was 38-year-old female. She's a resident of Kalyan and housewife by occupation. She presented with the chief complaints of multiple small and large joint pains since last 4 years, uh, inability to get up from squatting and sitting position since last 3 years, and inability to raise her both upper limbs above the shoulder since last 2.5 years.
Slides are not moving.
It's not getting moving forward slideshow actually.
Mr. Prasad, just see.
Hello.
Yeah.
Ma'am, I could not move forward my slides.
Okay, so you would like to just read it out and maybe
Yeah, you can continue narrating, no
continue.
problem.
They can stop and ask you questions. Yeah.
Okay, ma'am. Okay.
Yeah, you can. You have it written somewhere. You're on your laptop. They're moving, no?
Yes, yes, ma'am.
Yeah. So continue to present. Yeah. Okay.
My patient was 38-year-old female. She's a resident of Kalyan and housewife by occupation. Presented with the chief complaints of multiple small and large joint pains since last 4 years. She has also complaints of inability to get up from squatting and sitting position since last 3 years and inability to raise her both the upper limb above the shoulder since last 2.5 years. Then coming to history of presenting complaints, my patient was apparently all right 4 years back when she noticed pain in small joints of hands, elbows, knees on the both the sides with an early morning stiffness which was lasted for greater than 30 minutes. These symptoms were gradually worsened over the period of few weeks to develop an inability to grasp the objects like toothbrush, then kneading the dough, and which was more in the morning hours, which was insidious in onset and gradually progressive in nature, and used to relieve with a hot water bath or with activity as the day progressed. Patient initially used the over-the-counter pills, but later sought an medical attention as symptoms were worsened. The patient responded well and was in remission after 6 months of treatment in the form of once weekly oral medication. Then patient noticed inability to get up from squatting position and sitting position since last 3 years, which was insidious in onset and gradually progressive without any joint pain and swelling. Initially, patient was able to lift herself up with the support of upper limb, but later she was unable to get up even with the support. This was associated with the pain in the both the thighs. Later, patient noticed inability to raise her arm above the shoulder and inability to comb her hair 2.5 years back, which was insidious in onset and gradually progressive in nature. For this, patient again sought an medical attention and improved on medications. And patient was able to comb her hair and could stand from sitting and squatting position. But since last 6 months, she again developed weakness and patient was unable to get up from sitting position with the support. However, patient can lift her head. Patient could lift her head above the pillow and she could turn in the bed, and there is no history of slipping of footwear or any difficulty of holding in the footwear or buttoning or unbuttoning herself or feed herself. Then coming to a negative history, there is no history of alopecia, recurrent oral ulceration, malar rash, photosensitivity, or rash over the upper limb or lower limb. Then there is no history of fever, breathlessness, cough, or roughening or cracking of the skin of the tips and sides of the finger. Then there is no history of Raynaud's phenomena, difficulty in swallowing, skin tightening, or breathlessness. Then there is no history of dryness of eyes, dryness of mouth, or any glandular swelling. Then there is no history of facial puffiness, swelling over the back or neck, or any discoloration of the skin of the abdomen. Then there is no history of diplopia, ptosis, or any diurnal variation of the muscle weakness. And there is no history of muscle fasciculations or muscle wasting. Then past history. No similar complaints in the past. She is not a known case of diabetes mellitus, hypothyroidism, ischemic heart disease, or hypertension. and there is no history of tuberculosis in past. Coming to a personal history.
Dr. Onkar, slide is
Just wait a minute.
Yeah, we'll just try once again. Otherwise, then you can just stop him and ask questions and like a case presentation, regular case presentation. Just go to the next slide. It's moving. Not happening? It's happening. Yeah. Okay, just where you were.
Omkar, you can go to the slide that you are.
You were
talking
talking about personal history, no?
Personal
Yes,
history.
to that slide, yeah. Yes, personal history, yeah. Stop.
Yes, ma'am. On personal history, her sleep was normal. Personal history, her sleep was normal, appetite was normal, and bowel bladder habits were regular. She is mixed by diet and she denies any addictions. Then coming to a treatment history, patient was on tablet methotrexate 15 mg once weekly along with the folic acid 4 years back for a period of 1 year. Later, which was followed when patient developed a muscle weakness in the both upper and lower limb 3 years back, then tablet methotrexate dose is increased to 25 mg weekly along with the tablet prednisolone 60 mg, that is 1 mg per kg for period of 4 weeks. Then tablet prednisolone is tapered by 5 mg per week till the dose of 5 mg over the 3 months, and patient was on tablet prednisolone 5 mg till last 6 months. However, since last 6 months, patient had worsening of the muscle weakness, so prednisolone increased to the 20 mg for 4 weeks and then tapered by 2.5 mg per week. However, on attempting the tapering the steroids, the patient has worsening of the muscle weakness. Coming to an obstetric history, she has regular menstrual period of 28 days cycle with no evidence of any bad obstetric history. To summarize my case, the patient is 30-year-old female with history of chronic inflammatory polyarthritis and insidious onset gradually progressive proximal muscle weakness in both upper and lower limbs without any evidence of distal muscle, ocular, facial, bulbar and neck muscle or any truncal weakness, and without any sensory or bowel bladder involvement. The possibilities could be an overlap myositis like overlap with RA or SLE, and second possibilities could be an idiopathic inflammatory myositis.
Okay, so Omkar, why have you kept overlap myositis above inflammatory myopathy? Can you
Because
specify?
sir, first my patient first started with the inflammatory arthritis. The histories of inflammatory arthritis 4 years back, with which was lasted with the she has history of early morning stiffness and which was improved on activity. So it more points toward an inflammatory arthritis. So it could be any inflammatory arthritis. The possible differential could be RA or SLE or MCTD. So we kept that overlap myositis as a first diagnosis.
But some patients of myositis themselves can have arthritis also without having
Yeah,
overlap.
yes, sir. Yes, sir. But the beginning of the arthritis was the first, sir, actually. In the patient of myositis, the myositis and arthritis are usually concurrent. Here, patient first started with an inflammatory arthritis. So I put the diagnosis of overlap myositis with RA as a first.
Anything else apart from these two, like these are autoimmune conditions, anything else you ruled out? You told in the history, in your history. So anything else you thought about and then you ruled out on history?
Uh, like sir, there is no distal muscle weakness. Then there is no neurological involvement. There is no diurnal variation. So neurological possibilities like myasthenia gravis or any motor neuron disease is ruled out.
And what about any weight loss or any other systemic symptoms? Fever
No,
or
sir.
weight
There,
loss? So
there
you
is
did
no
not mention
history.
about, you said appetite is normal, but
Yes, sir.
was there any weight loss?
No, sir. There is no history of any weight loss.
Any any swelling or anything, any lymph node or any abnormal lump in the body, anything like that?
No, sir. There is no history of any weight loss, recent weight loss, or any evening rise fevers, or there is no history of any swelling or lump in the body.
Why are these important?
Usually to look for any neoplastic etiology, sir. The malignancies are usually associated with a muscle weakness, but there is no history pointing towards recent weight loss or any loss of appetite or any night sweats or any glandular swelling in the body, sir.
So Dr. Pooja has asked in the chat box of why not steroid-induced myopathy second time, and why did you think about?
Sir, the points disfavoring the steroid-induced myopathies are, first of all, the patient responded to the steroid well. She has a muscle weakness. Prior to that, there is no history of steroid intake. This is the first point. Second point, when we started her on steroids, her weakness has been improved rather than deteriorating. So this is less likely and down the card that she has steroid-induced myopathy. Then, sir, the CPK levels, usually on investigation, on the history basis, these are the points favoring, and there is no history of any Cushingoid phases or any discoloration of purple striae, or there is no history suggestive of this thing, sir. So steroid myopathy could be on down the card, sir.
Okay. Dr. Samir, you want to ask anything?
What would be a subtle sign of muscle involvement in the nasopharyngeal region? What can you ask the relatives of the patient?
Any history of snoring, sir,
And
and any nasal twang or any change of voice?
yeah, correct. So this is many times ignored, not really noticed.
Yes, sir.
What happened to the arthritis? Did it progress? Did she have any kind of deformities develop over these 4 years?
No, sir. When she's presented 4 years back, she has inflammatory arthritis. But when we start on once a weekly and oral medication, her arthritis part has not progressed, sir. But she has intermittent only polyarthralgias without any stiffness while on treatment. So there is no history of like synovitis or swelling of the joint, but intermittent arthralgias were there, sir. But there is no obvious deformities.
Okay. Why did you not consider polymyalgia rheumatica?
Sir, polymyalgia rheumatica, there is diffuse aches and pains, but she
So
has
what is the first reason? First reason why you will not consider it?
first is age, sir.
Correct. Second,
First is age.
What is the age criteria?
Usually older age, more than 50, 55 years, they qualified for polymyalgia rheumatica.
yeah, patient has to be over 50 years of age.
Yes.
It would be extremely rare that we would even think of it below 50. And
Yes, sir.
suppose this patient was 50 years of age, then what would make you think of, whether it is PMR or whether it is myositis?
Uh,
What is a
Sir,
differentiating factor?
ESR and CRP, sir, usually on
No,
investigation.
clinically. Right now we are seeing the clinical features.
Okay. All the joints and all the muscles are involved, sir, clinically. Here, the history suggests you have more of a proximal muscles.
Okay.
So,
How does polymyalgia rheumatica present?
usually the polymyalgia rheumatica presents as the diffuse. First, you start with a generalized weakness. The patient has easy fatigability, generalized weakness, and
Are you
both the
sure?
shoulder. Sorry, sir.
Are you sure that the patient starts with weakness?
Yes, sir. Low grade
Okay,
fever.
what is the, see, it is all in the terminology itself. What
Yes,
is
sir.
it? Polymyalgia means
Multiple pain in the muscles, sir. Polymyalgia.
correct.
Yeah.
So,
So patient has pain in multiple muscles, like including proximal as well as distals.
Is it so?
proximal and distal both, you feel that is how it starts?
Usually begins with an proximal, sir.
Okay, what happens in polymyalgia rheumatica compared to myositis?
Uh,
What is the pathology? What is the difference between the two?
uh, Polymyalgia rheumatica. Sorry, sir, I could not hear.
What is the difference in the pathology between polymyalgia rheumatica and myositis? What is the key? What is the fundamental difference? Like,
Myositis is an inflammation of muscle itself, sir. Whereas in polymyalgia rheumatica, there is no as such inflammation of the muscle. Yeah.
So what is
So
what happens in polymyalgia rheumatica?
Usually there is a muscle there is diffuse aches and pains, and in
Okay, no, we are
polymyalgia.
not. No, so polymyalgia rheumatica is something you have not looked into because of the age of the patient, but you should know
Okay.
a key difference and you should know what it is. Like, is it a joint problem? Is it a muscle problem? You need to read up on that in detail, right?
Okay, sir.
So,
Yes.
right. So because you said you started with arthritis as the primary manifestation, right? So you're
Yes,
first
sir.
thinking of inflammatory arthritis. So is
Okay.
polymyalgia rheumatica an arthritis or a muscle problem?
It is usually arthritis plus there is stiffness and pain of the muscles, sir, usually.
Okay, fine. I think you'll need to go, that is correct, but you'll need to go a little more into detail about that later. So,
Okay, sir.
okay, had the patient taken any kind of, you said OTC medications were taken. So, what were the details of the OTC medications? Have you taken them up?
Sir, usually the patient does not have details of that OTC medication, but she has one strip of the empty pocket, that is the tablet was aceclofenac was there, sir.
Okay, was she taking any herbal supplements also?
No, sir. She was taking from there were no herbal supplements. She was taking proper allopathy medication, sir, OTC.
Would you think of any reason why she could progress from arthritis to suddenly then muscle weakness becoming the predominant symptom? So whenever this kind of thing happens, we are thinking, was there any medication induced
Yes, sir.
reason? That is why Girish sir was also asking regarding the steroid induced
Steroid.
myopathy.
Yes, sir.
Right. We
Steroid
have to be
myopathy.
very detailed about that. Yeah.
Yes, sir. There is no history of over-the-counter steroids, sir. Plus, there is no history of Cushingoid faces or any purple stripe. So
Is
this
it
point,
necessary to have Cushingoid facies or purple striae to develop a steroid myopathy?
no, sir, as such, no. But on history basis,
Right.
yeah.
Right. So it is not necessary. You can start steroids and the patient can develop myopathy very rapidly.
Yes,
And
sir.
you don't need to have a chronic steroid overdose as a reason.
Yes, sir.
You can go ahead, Girish sir, with any question.
Dr. Girish, you want to ask anything else before he goes on to the examination?
No, he can go ahead. Only thing, the patient developed myositis while on methotrexate 15 mg. Is that it?
No, sir. When
Or
she developed myositis, the methotrexate was increased to 25 mg.
no, but she was taking 15 mg, when she developed myositis.
Yes,
Or,
sir. But
or
she
had
did
she
not
stopped?
sought any. No, sir. She did not sought any medical attention when she developed muscle weakness for a period of at least 1 year. So the dose of methotrexate was 15 mg only, sir.
But she was taking methotrexate even without prescription during that 1 year.
Yes, sir. She was self-medicating and she was taking
Okay.
methotrexate during that period, sir.
Okay. Go ahead, please.
Are there, Onkar, are there any medications you would specifically ask for? That have you taken this, which could have contributed to developing myopathy?
Yes, sir. I asked specifically for the statins that she
Right.
can, during the period of this 1 year, whether she was taking statins or whether she was any chloroquine or any hydroxychloroquine that can contribute to an myopathy, sir.
Right. Is
So
there
I have
any
asked,
other medication that we commonly use for inflammatory joint diseases, which causes myopathy? Acute painful inflammatory joint disease, certain medication.
uh, colchicine.
Right. So what kind of myopathies does statin cause?
Statin usually can cause, usually the necrotizing myopathy can cause by the statin, sir.
No, wait. What does statin usually cause? Since you're saying usually, so what
Yeah,
does statin usually cause?
they cause the rhabdomyolysis, sir.
No. Okay. So we're talking about what would frequently happen. Suppose a patient of yours came with myopathy and is on statins, right?
Yes, sir.
Generally, what does statin cause? Does it cause
Muscle weakness,
rhabdomyolysis in large number of patients, or does it cause something else?
myalgia. It causes myalgia and generalized weakness, sir, actually, rather than.
Right. Right. So when would you suspect that this statin is now causing myositis or myopathy? What would you think of doing to see if this statin is now going to damage my patient?
When the patient has myalgia, generalized diffuse aches and pain, with the if there is any swelling associated over the muscle, then we can think of that
No,
statin
see,
is
now
causing.
you have a patient who is on statins and has developed muscle weakness. Now you want
Yes.
you want to do a particular test to check
Okay.
whether the statin is causing muscle damage or is it just causing muscle weakness.
Yes, sir.
What is the
So
test you'll
CPK, enzyme, sir, muscle enzyme, CPK usually,
and
and HMG-CoA antibodies,
right.
HMG-CoA receptor antibodies. These are the two
So
tests.
so what is HMG, the presence of anti-HMG-CR,
Yes.
what does it do to the muscle? What is the type of myopathy it causes?
It usually causes a necrotizing myositis.
Right. Okay,
Yeah,
suppose a patient comes to you and you check for anti-HMG-CR. It is positive, but there is no history of statins. Is that possible?
Yes, it can be possible, sir. It can be possible in IM, autoimmune necrotizing myositis, immune-mediated necrotizing myositis.
Right. So in fact, it is anti-HMG-CR is frequently found in immune-mediated myositis and
Yes,
sometimes in statin-associated myositis.
yes, sir.
Go ahead. Go ahead.
Go to examination and investigations.
Yes, ma'am. On general examination, the patient was conscious, oriented to time, place, and person, and examined in supine position in the presence of female attendant. Her weight was 55 kg, her height was 160 centimeter, and BMI was 21.4 kilogram per meter square. Her temperature was normal. Pulse was 98 per minute with regular rhythm in right radial artery with no radial or radiofemoral delay. Her blood pressure was 114 by 18, right arm supine position. Her respiratory rate was 18 per minute. There is no pallar, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Her JP was normal. And there is no evidence of any rash on head to toe examination. On head to toe examination, there is examination of hair, there is no alopecia. and there is examination of face, there is no rash over the face, but as the patient has muscle weakness, we have evaluated the detailed signs, that heliotrope sign, V sign, Shaw sign, Gottron's papules or any rash or Holster sign, it was absent in this patient. On the joint examination, both the hands, MCP joints, bilateral wrist joints, bilateral elbow joints and bilateral knee joints has tenderness. There is a synovitis of right second and third and left second MCP joints was present. The tender joint count was 14 by 28 and swollen joint count was just 3 by 28. There was no deformity and there is no local rise in temperature. So this is a tender joint count of 14 by 28 and the swollen joint count was 3 by 28. Then on systemic examination, the CNS examination, her higher mental function was normal. Her cranial nerve examination was within normal limit. Then coming to a sensory system examination, the touch, pressure, pain, temperature, and joint position sense and vibration sense was within normal limit. The tactile localization, 2-point discrimination, stereognosis, and graphesthesia was normal. Then the motor examination, her tone was normal in all the 4 limbs and the nutrition was normal. Coming to an power, her power in the shoulder joint on the right side and the left side, both in the adduction, abduction, flexion, and extension was reduced to the 3 by 5. And the power in the elbow in the flexion and extension was reduced to the 4 by 5. However, the power in the wrist and both flexion and extension was 5 by 5. While examining the power in the lower limb, in the power at the hip joint in flexion, extension, abduction, adduction was 3 by 5, and on the knee in the flexion and extension it was 4 by 5, but the power of the ankle was normal. In the manual muscle testing, we tested for the 8 muscle. Her score, MMT score was 106 by 150. Reflexes, she has 2+ reflexes of biceps, supinate, triceps, knee and ankle on the both the side, right side and left side. And superficial reflexes like corneal reflex and abdominal reflex was present. Her plantar was flexor bilaterally. The cerebellar signs was within normal limit. The skull and spine examination was within the normal limit and meningeal signs were absent. Coming to a cardiovascular system, there is S1, S2 is normal. There is no murmur. And respiratory system, their air entry was equal on the both the side. No adventitious sound heard. There were no crepitations. And on per abdomen examination, there is soft, non-tender, no organomegaly and deep palpation. Then to summarize my examination findings, the 38-year-old female with inflammatory arthritis and bilateral symmetrical proximal muscle weakness of bilateral upper and lower limb with preserved superficial and deep reflexes without any sensory involvement. Then the possibilities could be an RA with overlap myositis, and second again could be idiopathic inflammatory myositis.
Again, patient has not developed any deformities over 4 years of arthritis. So,
Sir, usually
and she has not
is
followed
the
up also with you regularly. So in in between
she
one
was on methotrexate, sir, meanwhile, for 4 years, and she has only intermittent flare of an arthritis. So that's why that might be the
that means
reason
the
she has not.
arthritis was not it was not well
Sorry,
controlled. If she had
sorry, sir.
intermittent joint pains or swelling, that means arthritis was not under control.
Yes,
Still,
sir.
she did not have any deformities. So do you still feel it is RA or is it just myositis with arthritis?
Usually the non-deformative, then it could be a myositis with an SLE also. That is incomplete presentation SLE myositis also, because she
Why?
don't have
Why not
deformity
just
for the
any particular syndrome what we call with associated with myositis?
antisynthetase syndrome. That can be a particular syndrome, sir.
So why don't you think this is antisynthetase syndrome? Why do you think it is RA?
It can be possibility of antisynthetase syndrome also, but patient don't have any Raynaud's phenomenon or any ILD or any mechanics hand, sir, on examination.
Okay, but all patients will not have all the symptoms.
Yes, sir. So that's why it's
you spoke
lower on
about
the card, sir, antisynthetase syndrome.
You spoke about the skin signs. Can you
Yes, sir.
Can you tell me about Gottron's sign or papule? What are they?
The Gottron papules are the there is a red erythematous papules on the extensor surface of the finger, sir. And usually it is present on the elbows or on the knees and on the PIP joint, sir.
What about reverse Gotron?
With this, usually Gotron's papules or Gotron rashes are present on the extensor aspect. When they are present on the flexor aspect, then it can be labeled as an inverse Gotron sign or Gotron's papules, sir.
Okay.
What is the antibody association of inverse Gotron sign?
Uh,
Okay,
usually,
tell me. You can talk about MSA.
myocyte specific antibodies. These are anti-MI2 beta, then anti-MDA5, then anti-TIF1 gamma.
Can you tell about first about what is myositis associated antibodies and what is myositis specific antibody, autoantibody?
Yes, sir.
Difference
These
between
are
the two and what comes in between, like in these two.
Yes, sir. There are certain myositis specific antibodies, the anti-MI2 beta, anti-Jo1, then anti-MDF5, TIF1 gamma, then anti-NXP2, these are the SAE, these are the myositis specific antibodies, sir. And there are certain myositis associated antibody, like Rho52, PMSCL, then U1RNP. So these antibodies are myositis associated antibodies.
What is the difference in clinical picture in these myositis specific autoantibodies that you told about?
Sir,
तिरके कटाओ
uh, clinical picture, this presence of this antibody could differentiate the etiology, sir, usually. Like the TIF1 gamma or NXP2, they are more associated with the carcinoma, sir, usually occult malignancies. So older age group, then there is a usually fingertip ulcerations, then subcutaneous calcification. This can be associated with this antibody, sir. These are the clinical presentation if there is a ulcerative etiology, if there is a calcification. So if associated with this TIF1 gamma and NXP2, sir.
If how
Are you
many
sure about?
NXP2?
Yes, sir.
Are you sure about NXP2? Is it carcinoma associated or what something else?
Sorry, sir.
NXP2, you told it is associated with carcinoma. Is it? Are you sure about that or something else is the presenting picture?
TIF1 gamma is more associated with the carcinoma, sir, usually occult
What about
malignancy.
NXP2?
Usually it's associated with the rash, sir, like digital ulceration or any rash NXP2
It's more
and
of a
calcifications.
dermatomyositis associated rash. And in
Sorry.
TIF1 gamma, how much percentage of people are eventually found to have carcinoma?
Usually there is association 60 to 70% people with TIF1 gamma. They are associated with the
80%.
malignancy.
Around
70 to 80%, sir.
And what about other antibodies?
Then there are anti-synthetase antibodies, sir, Joe.
So what
So
antibodies come under anti-synthetic antibody panel? Like,
anti-Jo1 antibody, then anti-OJ antibody, anti-EJ antibodies. So these are anti-synthetase antibodies, sir.
anti-PL12, PL7, there are other also.
Yes, sir. Anti-PL12.
And what about anti-MDA5?
Anti-MDF5 is a nucleoside deacetylase antibody, sir. It is usually associated with an dermatomyositis also, MDF5.
What is the specificity? What specific condition is associated with anti-MDA5?
Anti-MDF5 is usually so it's a nucleolar antibody. The condition associated with the anti-MDF5 is usually amyotrophic dermatomyositis, sometimes associated with MDF5.
Any extramuscular manifestation?
Is the
ILD, sir.
Yes.
Interstitial lung disease and arthritis.
Any
No, what is
particular thing about this ILD? Is it slow ILD?
It's a rapidly progressive ILD, sir, usually.
What is the finding on the hands in anti-MDA5?
Sir, usually anti-MDF5, the hands are ulceration, or sometimes there is a arthritis is there, sir. And
Ulcers.
arthritis. MDF5 is associated with an arthritis, but there is a fingertip ulceration sometimes, and there is periangular erythema is also there, sir.
The inverse Gautrins, you said, no, sometime back.
Yeah,
Yeah.
inverse Gautrons is associated with it. So anti-NXP2, I think you've not got it right yet. So what is the association of if a patient comes to you and has an anti-NXP2 antibody positive? So what would you be worried about for the next few years?
Usually, sir, with anti-NXP2 positivity, we are worried about malignancy, sir, in next few years.
And
Upcoming
especially how
malignancy.
many years? How many years is the risk highest?
After age of 50 to 60 years, sir, risk is highest.
No, after diagnosis, for how many
Uh,
years are you going to
2 to
monitor
3
the
years, sir.
patient?
After
2
diagnosis,
years,
after in upcoming 2 to 3 years, sir.
right? What else happens with anti-NXP2?
Anti-NXP2, usually there is a ulceration, sir. Finger ulcerations are there. Calcinosis is there, sir, with anti-NXP2.
Calcinosis in which kind of patients, which category of patients you would find calcinosis in an anti-NXP2?
Usually juvenile patient, they sometimes has the calcinosis, sir, more predominantly.
Where is the calcinosis frequently found?
Elbows, sir, on extensor aspect, elbows, skin, then there is a more frequently we get a calcinosis, sir.
Which is one specific area where you can get lots of calcinosis?
Uh, sorry, sir, I don't know. I think
So
elbows.
you have to examine the trunk.
Okay,
So
yes.
that is when, so because systemic sclerosis maybe hota hai calcinosis, right? So
Yes, sir.
a particular feature of JDM would be a sheet-like calcinosis in the trunk.
Trunk.
Okay.
Okay. Yes.
And which of these antibodies is associated with distal myopathy?
Usually, inclusion body myositis, this is the distal myopathy, sir, usually. And inclusion body myositis is
Among
associated.
the myositis specific antibodies, is there anyone associated with distal myopathy? You can read up on that. Okay.
Yes, sir.
What is the
Distal
specific
myopathy.
antibody? You can check that out. It's anti-NXP2, but you can go more into detail about it. What is
Yes.
the specific antibody for IBM nowadays?
Anti C1N antibodies, sir.
Right. CN1A.
Yes, sir.
So why is this patient not have IBM?
Sir, usually IBM has older age group of onset. Coming to a demographic data, it's an older age group. Plus, it predominantly affect the distal muscles, and plus it has a neuropathy also, sir. Sometimes it is classic. It sometimes patient had distal neuropathies also. So the IBM is very less likely in this patient.
Which are the muscle groups more affected in an IBM? Suppose this patient was elderly. So
Yes,
which
sir.
muscle groups would you
Sir,
have
distal
expected?
muscles, sir.
Within the
Proximal plus
proximal muscles, which ones would you expect?
proximal muscles of shoulder, sir. Shoulders
Okay,
and
so there
distal
is a
muscles of hand.
particular muscle you have to examine in the lower limb, which can differentiate, which is most frequently affected.
Girdle, they have imbalance, sir. While walking, this patient has imbalance. The girdle muscles, pelvic girdle muscle, we can in the lower limb.
Okay, where will you look for muscle wasting in a patient comes with IBM? Where is the muscle wasting characteristically present?
Muscle wasting is usually seen in the area of the, sir, bilateral thighs or any quadriceps. There is wasting of quadriceps in the thigh region, sir, usually. And there is,
Specifically, you are looking at vastus medialis lateralis. Okay, so
yes, sir,
medialis wasting
quadriceps.
is most, not quadriceps. Vastus
Okay, okay,
medialis wasting is specific for IBM, right?
okay,
So
sir.
have you done the antibody testing for this patient?
Yeah,
Yes, sir. We have.
wind up in 5 to 7, 10 minutes. So yeah,
Yeah.
just finish this investigations, treatment, and feedback. Huh? Yeah.
Okay. Coming to CBC, her HB was normal. PCV, MCV, and MCH was within normal limit. Her platelets and WBC count was within normal limit. Her ESR and CRP was raised. ESR was 88 and CRP was 30 mg per DL. Her renal function tests were within normal limit. Coming to the liver function test, the patient has raised HGOT and HGPT. HGOT was 182 and HGPT was 209. However, alkaline phosphatase, albumin, serum protein was within normal limit, and the bilirubin was within normal limit. Then patient has anti-CCP antibody, which was a strong positive. And then ANA by IFA was 2+ speckle pattern. Her ANA blot and myositis profile, that myositis specific and myositis associated antibodies were negative. Coming to a muscle enzyme, when she presented to us 6 months ago, her total CPK was 3256, her LDH was 1022, and aldolase was 22 units per liter, and HGOT was 182. However, her TFT, thyroid profile, blood sugar level, and urine routine microscopy are within normal limit. Coming to the EMG NCV, the study suggests you have primary muscle disease. On EMG and NCV study, the study suggests you have primary muscle disease involving bilateral upper limb and lower limb muscles. The proximal muscle like deltoid and gluteus maximus are more significantly involved, showing abnormal electrical irritability with short duration and low amplitude motor unit action potential with active ongoing denervation. All these findings were suggestive of inflammatory etiology. Then we are done with the MRI of whole body. There is abnormal T2 stir hyperintense signal noted involving the bilateral gluteus maximus muscle and medius muscle, left greater than right. The bilateral supraspinatus, infraspinatus, teres major, deltoid, and trapezius and latissimus dorsi, there is hyperintense signal on T2 and stir imaging. Then we have proceeded with the muscle biopsy. Then muscle biopsy was showing this is the endomysial, the dense endomysial infiltrates of the lymphocyte and plasma cell with few eosinophils and multinucleated giant cells are seen in the around the endomysium cell. And there is as well as there is a perifascicular atrophy, and there is a atrophy seen, and there is a perivascular infiltrates also on the muscle biopsy. Then other investigation, her triple is that HIV, SBSS in HCV by ELISA was negative. Her 2D echo was within normal limit. For the screening of malignancy, we have underwent the HRCT chest and CECT abdomen. It was within the normal limit. So as she has RA and anti-CCP was strong positive, with synovitis on examination, we keep the final diagnosis as RA with an overlap myositis.
Go ahead with the treatment.
This is the trend of muscle enzyme. Usually, the patient started methotrexate 25 mg and steroids when she developed the muscle weakness 3 years ago. Her total CPK was 1512, LDH was 814, SGOT was 212, and aldolase was 24. On follow-up and tapering the steroids to 5 mg per day along with the methotrexate 25 mg. Her total CPK was 212, her LDH was 422, and SGOT was 84. This signifies the response to the tapering steroid and methotrexate. However, on methotrexate 25 mg per week and steroid 5 mg per day when patient presented to us 6 months ago, again she has total CPK of 3256, her LDH was 1022, and SGOT was 182. So we have increased the steroids and methotrexate 25 mg per week. We have increased the steroids to 20 mg per day. Then her total CPK to again come down to 422. Her LDH was 212 and SGOT was 74. So on the tapering of the steroid, patient has recurrence of muscle weakness, and as well as she has active RA. So option was rituximab was given to the patient. And we have planned for injection rituximab 1 gram as a steroid sparing second line immunosuppressant, and patient is vaccinated before giving rituximab. Currently, patient received 2 doses of rituximab 15 days apart, and we are tapering the steroids from 20 mg to 7.5 mg at the rate of 2.5 mg per week, sir. And after giving the rituximab, her MMT was improved to 138 by 150, sir, almost after 2 doses of rituximab and the steroids on 7.5 mg.
Ideally, how much gap do you need between vaccination and initiation of rituximab in ideal situation?
Usually 4 weeks, sir. There is a gap of 4 weeks before planning a rituximab and vaccination, sir.
And if you have already given rituximab and now you need to vaccinate the patient, how much will you wait?
We'll wait for another 4 to 8 weeks, sir, for vaccination. If we are already given a rituximab.
No, there is a logic behind it. It's much longer. So you have to look into that.
Okay, sir.
What other options you had about apart from rituximab in this patient? Suppose some
Sir,
patient
usually other option
afford
like
it.
azathioprine and mycophenolate mofetil, that were the other option we can consider prior to giving rituximab. Like azathioprine and mycophenolate mofetil, sir. These are the other options.
Any another new drug?
Sir, tacrolimus or IVIG can also be given, sir, in refractory cases.
Tacrolimus, yes, but it's not a new drug. So tofacitinib also now saying myositis can be used. It can be used for RA as well. So there are the other options.
Yes, sir.
Dr. Girish, Dr. Sahai, I think we'll have to wind up. Just give him a short feedback or conclude.
So I think Dr. Omkar did very well. The presentation was very good. Presentation slides were very good, and even presentation was very good. So there is still some room for improvement, especially reading about other conditions like polymyalgia rheumatica. We are not that confident about answering.
Yes.
So yeah, there is always scope for improvement. Overall, very good presentation.
Thank you, sir.
Dr. Samir?
Yeah, I echo the same. He found a nice case actually because it gave me that twist of a high anti-CCP. So that's what happens in clinical practice, and I think that's very important to understand for you, Dr. Onkar, that
Yes.
we many times get flummoxed. So you have to know several things. Just knowing a particular targeted thing will sometimes land you in a fix. So
Yeah.
it would be good to read around the topic a bit.
Yes, sir.
On the virtual platform, unfortunately, we can't discuss very long. So
Yeah.
it was a good presentation. Thank you, Dr. Girish, Dr. Samir, for sparing your valuable time on a Sunday. I thank
Thanks.
all of you. And Dr. Omkar, well presented. You can stop sharing your slides.
Thank you, ma'am.
Yeah. So please stay logged in for the next lecture by Dr. Lisa ma'am, Lisa Rajshekar ma'am. Ma'am, you can, you're there. Dr. Lisa ma'am.
Yes, Dr.
Yeah,
Kavita, I'm here.
yeah,
Am
thank
I
you.
clear?
Yeah, you're clear. You can just share your slide, first slide. Meanwhile, I'll introduce you. Yeah. So today we have a very senior, renowned, and well-known rheumatologist with us for a guest talk, Dr. Lisa Rajasekhar. Actually, she needs no introduction. She's so well known among all the rheumatologists of the country. But I'll just introduce her in brief. She is currently the dean at Nizam's Institute of Medical Sciences at Hyderabad. And she's been the professor and senior professor and HOD at the Department of Clinical Immunology and Rheumatology at Nizam's Institute for many years now. She is an alumni of PGI Institute, Chandigarh. She also did a research fellowship in rheumatology at Taiwan. She has written many book chapters on very interesting topics. She's got around 80 to 90 publications, out of which around 50% or more are in international journals. She's conducted multiple research projects, government and industry sponsored. Today, she is going to talk on a very interesting topic, which is very relevant to all rheumatologists and physicians, the complement-mediated pathway. So I welcome you, ma'am, to the Maharashtra Rheumatology Association academic session. Over to you. Thank you.
Thank you, Dr. Kavita. And I'm keeping my video off in the interest of the network bandwidth.
Okay.
Seems to be a little unstable at my end.
Sure,
so please excuse me for that.
No problem. Yeah.
And thank you very much for giving me this opportunity. It's actually my privilege to share with you today, all of you who are here, my current understanding of this very complex field of complement system and how it impinges on our practice in day-to-day life as rheumatologists. During this talk, which I think will take me around 25 to 30 minutes to complete, I will give you an understanding of how the complement system is organized, a little mention here and there about how it is involved in normal immunity and how this organization helps us to understand the diseases in which complements have a significant role to play. Understanding this complement system becomes increasingly important because the scientific world is really progressing in this field and is trying to understand this part of the immune system as we grapple with more and more refractory rheumatic disease. So we are trying to look for targets which will help us to improve patients who have diseases which are defined by disruptions in the complement system, or those which have the complement system as an additional pathway which is significantly impaired. So while we have understood this, the physiology of complements have also been better understood, and they are present not only in the fluid phase, not only on the surface of cells, but also intracellularly. And I'm sure the younger people in this audience will be studying this field with in greater depth as they face challenges in their clinical practice. Uh,
Slide is not changed, madam. I think. Mr. Prasad, you're there? Mr. Prasad?
are kind of little different from the other molecules which are labeled from C1 to C5. The story of this complement system is focused on the three pathways which ultimately culminate in the membrane attack complex. And these pathways have their identities, they have a lot of commonalities, and we will discuss this as we go forward. If you have to understand the complement pathway, it is easy kind of to visualize it as a cleavage cascade. So the proteins are cleaved, and the proteins which are cleaved are C4, C2, C3, and C5. And cleavage products are many, and they have their own names. These names have kind of stabilized over the years. There are few tweaks in these nomenclatures happening, but for a large purpose, we have the C4 getting cleaved to C4, A, B, and D, and I will discuss these in a little more detail as we go to these individual molecules. So the classical pathway starts with the, if you can imagine this diagram to show the orange, if you can imagine the, the bulbs on the orange part of this diagram, if you believe them to be, pathogen associated molecular patterns, so that orange surface is actually the surface of a bacteria, imagine it. And the blues are the antibodies on these bacteria. And these antibodies can be either IgG or IgM. When they are IgG, then you need many more molecules on the surface of these microbes. When you have IgM, with lesser number of molecules, you can have a lot more happening in the downstream pathway. So when this kind of interaction is present on the surface, this is an immune complex. And at that point, the complement system is activated. And in the classical pathway, the first part of the complement pathway is the C1q molecule. So the C1 has three, the C1q, the C1r, and C1s. The C1r and s are basically enzymes. They are serine proteases, and they bind to C1q, and this trimolecular complex kind of is the next step of this process of immune complex formation and complement activation. In the lectin pathway, the activation happens by molecules which are present on the surface of fungi or other bacteria, and these may be mannose, these may be glycans, and a few others are also present. But for for understanding the principles, we can keep in mind mannose and glycans. And these also then activate homologues of the C1q and C1rs of the classical pathways. And these are the collectins, the mannose binding lectins, and the ficolins, etc. But they are homologues basically. And the C1rs of the classical pathway finds its counterpart in the serine proteases of the lectin pathway. Now, what happens after this is that the next two molecules, the C4 and the C2, they combine together, they are cleaved, and they form the C3 convertase. Now, the C3 convertase, what it does next is it breaks down the C3 into C3A and large numbers of C3B. And these C3B basically are the opsonins. They are the ones who will now go and attach to this complex here. And once this entire complex is formed, which includes C3B, then the next step in the pathway happens. Leaving these two pathways aside and looking at the alternate pathway is basically in a state of low grade activation. So the C3 molecule is existing in a isoform, not an isoform really, it's hydrolyzed by the presence of circulating C3 convertases into a hydrolyzed form of C3, which resembles actually the C3b molecule of the generated in the classical and the lectin pathway. So this whole process is basically happening as a takeover, and this is the classic takeover where you have a spontaneous formation of C3, which actually is C3b resembling molecule, which means that it is active, that it is an absolute. Now C3a is moves into the fluid phase, and C3b gets bound to surfaces. Now, when this happens, the factor B attaches to C3b and a pro-convertase is formed, which then combines with factor D to form a C3 convertase of the alternate pathway, which is basically in the fluid phase. So your C3 convertase is basically a combination of the C3b and a portion of the factor B, which is not present in the classic and the lectin pathway. So C3b, BB is the C3 convertase of the alternate pathway. Properdin is another circulating molecule. It stabilizes this C3 convertase. So because properdin is present, C3 convertase is stable, and so it is able to pass through or regulate the activity of C3b. It is able to further cleave C3b and move forward. Another important principle in the complement pathway, which is used in therapeutics also, is the amplification loop. So what happens is that the C3 convertase which is present, it amplifies the loop, and more of C3 is now broken down by the C3 convertase into C3b BB. So more and more of this is formed, and as a result, the next step, which is more of the broken down factor of factor B joins with C3b, more C3b joins to this, and this makes the C5a convertase. C5a convertase breaks down C5 into C5b and A, and we all know that C5a is the anaphylactotoxin with which we are very familiar. C5b is a split product. So coming back to a little more detail about these individual molecules, just a recap that C1q was the central molecule or the initiating molecule of the classical pathway. Now this molecule has been described to have three major regions. The most upper part of it is the globular region, the middle collagen-like region, and an N-terminal region with a disulfide bond at the other end, the lower end. Now, in the globular head also, there are 18 polypeptide chains, 6 of each type, 6 of A, 6 of B, and 6 of C. Now, this is important because A is well conserved, B and C are not conserved. They dimerize with each other, and they are basically the part of the molecule which go and attach to the Fc portion of the antibodies, and they are the initiators of the classical pathway. While this is very well known, what is also discovered that this C1q molecule also modulates the activity of T cells, B cells, and is important for neuronal synapse formation, so that when you have genetic defects in C1q, either in the A gene, B gene, or C gene, you will have not only complement deficiencies, not only infections or autoimmunity, but you may also have neurological defects. So, not unsurprisingly, defects in these genes have been well described. Defects in C1q, A, B, and C have been described in many case reports. And we ourselves had the chance to experience C1q mutations in 2 of our cases of young children with lupus or lupus-like disease, and I'll describe them next. So the first child we saw who were discovered to have lupus due to a monogenic cause had a C1q mutation. She was a 2-year-old female. Her parents were first cousins. She had the classic lupus. She had acute cutaneous lupus, oral ulcers. She had a myelitis. She had lupus nephritis. She had low complements. A dsDNA was positive. She also had recurrent infections in the form of thigh cellulitis and thumb abscess. Another child had incomplete lupus and she had mutation in the B polypeptide chain of the C1q molecule. She was 2 years old. Her parents were non-consanguineous marriage. She had fever, oral ulcers, discoid rash, but nothing to complete the major organ manifestations of lupus. She had a lot of autoantibodies, but in her case, the complements were normal. There was no family history and there were no infections. So the phenotype of C1q deficiency has been extensively covered in literature. What I wanted to show in this slide was the fact that we have descriptions from India, and also that in the major paper which describes a large cohort, you will see that most often patients with C1q deficiency present with cutaneous disease. You see the darker shaded in the first panel, and a lot of them have oral ulcerations. Glomerulonephritis can happen, bacterial infections can happen, but it is important to note that a lot of patients may not have bacterial infections also. So a very small point here, not major relevant to this topic, but it is important for us practicing physicians or rheumatologists to know that in C1q patients, we could use C1q replacement strategies with the help of fresh peripheral plasma. And there are 2 case reports in which one of them had a successful transplantation with a hematopoietic stem cell. Obviously, these patients who have demonstrated infections may benefit with vaccination program. Now, moving on to describing the C4 molecule a little, it is in our minds associated with low levels in active lupus disease. While that is true, but the effect or the need or the importance of C4 has also been understood in little areas. And I'll just briefly tell you about the C4 molecule before we understand the split products and autoimmunity. So the C4 molecule basically is modular and it has 3 parts. And when it is cleaved, the molecule C4A, which is formed, is actually a strong inhibitory anti-inflammatory molecule. So it not only impairs chemotaxis, but it also impairs C5A anaphylatoxin induced defects in the vasculature. So basically, C4A is a very important anti-inflammatory molecule. So the remaining product is C4B, and there are regulators present in this system circulating in the blood, which will kind of bind the C4B, take them out, and so regulate immunity, regulate the complement system. In the next part of cleavage, the C4D is formed, and a lot of you, there are people in the audience I know who have worked on C4D as biomarkers of disease activity in autoimmune disorders. And yes, C4D split products on tissues have been considered to be important markers to identify a renal disease as being related to autoimmunity or related to the complement or complements being the major part of that person's pathophysiology. Another complexity of C4 is that it has 2 isoforms, C4A or C4B, and each individual may have C4A or C4B number of copies differently, and deficiency is associated with diseases like lupus, even malignancies, diseases like celiac disease and sarcoidosis, and inconsequential to autoimmunity. But a note that some of these patients also have higher adverse reactions to antimicrobials. In lupus, as I have said, low levels may be associated with complement activation. But what experts in the field say is that even in patients with lupus, where you have very low C4 levels, it is wise to see these levels sequentially, because those patients who exhibit an improvement in C3, C4 levels reassure the physician that they are less likely to have a flare. However, we have seen patients who are in remission for a long time but have a consistently low C4 levels. And some experts believe that these who have a low C4 level consistently are probably having a low copy number variation of the C4 gene. The C4 deficiency induced lupus is slightly different from the normal lupus in that it does not have a high ISD gene secretion. Now, to complete discussion on C4, I will refer to the C4 nephritic factor, which is nothing but an autoantibody to C3 convertase. So if you recall, the C3 convertase, the classical pathway, is a C4b2A combination. And autoantibodies to this C3 convertase are associated with human disease like post-infectious glomerulonephritis, systemic lupus erythematosus, and other renal disorders, and even meningococcal disease. Moving on to C3, which is the central molecule of the complement system. It is at the heart of the complement system. And C3A, C3B are very well-known terms to all of us. A little more complexity about C3B is that C3B gets further cleaved, and it gets further cleaved through molecules like C3F and C3C, which are not surface bound. They are in the fluid phase. But IC3B and its further breakdown products, the C3D and C3DG, which are surface bound. So what actually, if you need some help in remembering these different kind of subunits of C3B, remember it that yes, we have C3A, we have C3B, we also have C3C, we have C3D, C3E and F are products which are not really linked with disease. The C3DG is almost synonymous with C3D. So what we really need to focus on is the C3B molecule, especially the IC3B and the C3D, which have important connotations in human disease. I will be discussing them, and which need to be regulated and which have important regulators, which again I will be discussing in the next few minutes. So moving on to the complement regulators. The complement regulators are many. Most of them I have listed here. All that are listed here are negative regulators. So the most important is the complement receptors themselves, which bind the complement products and hence are important to stop the complement cascade. The complement receptors which do this function are the complement receptor 1 and the complement receptor immunoglobulin-like family molecules. Factors H and I have not yet described. These I have not yet described. These are negative regulators of the complement cascade, both in the classical lectin pathway as well as the alternate pathway. DAF, which is nothing but CD55, is well known to all of us as the factor whose deficiency is associated with paroxysmal nocturnal hemoglobinuria. MCP is little less well known, but it is a membrane associated protein, which is also called CD46, and is a very important negative regulator of the complement cascade. C1 inhibitor, which is also called the C1 esterase inhibitor, is well known to us. What I have not listed here is properdin, which I told you is a positive regulator of the alternate pathway C3 convertase. Now, the complement receptors are actually not just CR1 and CRIG, but there are 4 classes of transmembrane proteins, and CR2, CR3, C4, as well as the C3A and C5A receptors are included as complement receptors. Now, the C5A and the C3A receptor anaphylactotoxin receptors are important. We have already molecules which target these and which are being used in diseases that we know. The C3A and the C3A receptor interaction is also very important in normal human physiology because it helps to maintain the germinal center. The CR3 and CR4 are basically integrins. I may have slides coming up, but what these integrins basically do is they are adhesion molecules. And some of you may remember that CD11B, CD18 is the molecule or the integrin whose deficiency is associated with the disease called leukocyte adhesion deficiency, immunodeficiency, in which patients have a lot of pus, but that is devoid of neutrophils because these neutrophils are not marginated to the periphery. So this is about CR3 and CR4 a little, and so let's move forward. So the disease which most of us know that the ANCA vasculitis has shown to be associated with activation of the alternate complement pathway. So what happens in this disease, whatever we know till now, is that these neutrophilic antibodies, they prime the neutrophils, which starts the complement cascade, and it is the alternate pathway which is majorly activated. And as a result of this activation, we have the formation of a lot of C5a. And so one of the molecules, avocapan, which acts against the C5a receptor, which I just described, has been tried in ANCA vasculitis as a steroid-sparing agent and has been shown to be non-inferior to prednisolone in maintaining remission at week 24 and superior to prednisolone in maintaining remission at week 52. We still, to the best of my knowledge, don't have this molecule with us. But as you can understand, that we are trying to use complement-based therapeutics in wherever we find evidence of complement activation in our diseases. Now, I will briefly describe CR2 receptor, which is also called CD21. What is important to note here is that this is not a regulatory receptor. This is a receptor which helps the complement proteins to do their functions. So these are basically majorly found on B lymphocytes and follicular dendritic cells. And the ligands for this. So if you imagine that these purple V's are the CR2 receptors present on the follicular dendritic cells and the B lymphocytes, then the major ligands are the split products of the C3, which I have described in the previous slides, the IC3B, C3D, C3DG. So CR2 binds these, and with the help of a cofactor, its cofactor, factor I, allows these molecules to be internalized, to be removed from the circulation, and thus acting as a negative regulator or an effector of the complement pathway. The CR3 and CR4 I have already talked about. The CR1 actually is one of out of CD35. It is important to remember these CD names because when we do tests for these complement pathways during the flow cytometry, then these words are used to describe what we are trying to ascertain in the flow. So CR1 is basically the major complement regulator, complement receptor protein. And again, I have tried to visualize them on cells which are in green and the receptors themselves which are in purple V's. So what I want to say in this slide is that CR1, the circulating CR1 in human body, 90% of it is present on RBCs, but it is also present on phagocytes, monocytes, B and T lymphocytes. The importance of knowing this is that this is important in cold agglutinin hemolytic anemia because this complex, which consists of the opsonin C3b on a surface of autoantigen immune complex or a pathogen related immune complex, is R1 is the major binder of this C3b and has again factor I as its cofactor, but this surface bound is taken up with the RBCs and transported to the liver and spleen, So when you have a disease in which you have pathogenic antibodies to the surface of RBCs, then a lot of it goes through these into the liver and spleen and results in extravascular hemolysis. Another important regulatory molecule is the CRIG, which is a key receptor for picking up C3b. It is present on tissue resident macrophages. So from those macrophages, they now pick up these opsonized, danger molecules or pathogen molecules. What CRIG does is it prevents the binding of C3b to its own substrate where it would have ultimately led to inflammatory damage. And it is a potent inhibitor of C3b even in the alternate pathway by acting on C3 convertase. In fact, we have nanobody therapies which target the binding site of C3b on CRIG. Now, the C1 inhibitor is basically an esterase inhibitor, and it traps the C1RS or its homologue, the MASP1 and 2, and thus prevents activation of the contact pathway, which would have resulted in release of bradykinin, etc. So that if you have deficiency of this inhibitor, then the complement cascade is not regulated, and we have a disease which is well known to all of us, the hereditary angioedema. Therapeutics in this area have led to the manufacturing of recombinant C1 esterase inhibitor, which is now used and approved as therapy for HAE. And now why I have brought you back to the alternate pathway diagram is because we need to understand the major regulators of the alternate pathway. And these are the factor H, factor I, and the DAF. DAF and the MCP. So if you look at the bottom left corner, it is basically a diagram which shows how the factor H interacts with the C3b, which may be present on the surface of cells or tissues, and that this factor H is also interacting with another negative regulator, which is the MCP. Now, this close interaction is very crucial so that if you have gain of function mutations of C3, then it doesn't decay. If you have loss of function of mutations of FH, then the complement system goes on generating more and more C3 convertase, C5a convertase, C3a as anaphylatoxins, C5a as anaphylatoxins. And similarly, if you have deficiencies of MCP, you will have hyperactivation of the complement pathway. Now, we know diseases like a typical hemolytic uremic syndrome. We know diseases like CHAPLE, which are associated with deficiency of DAF, which not only leads, DAF not only leads to a PNH-like disease, but it also leads to a disease in which you can have protein-losing enteropathy and a lot of thrombosis, which is called the CHAPLE disease. It is important to keep this in mind because therapies against these factors, in those patients where we have deficiency of these factors, we can give proteins, recombinant proteins, to alleviate these deficiencies. The CFH, so the factor H mutations were described actually, I think 40 years ago, when the first complete deficiency of factor H was defined in a patient who presented with a typical hemolytic uremic syndrome, which is characterized by hemolysis, renal failure, and thrombocytopenia in the absence of a gut infection with the enterotoxic Shigella. So if you don't have a gut infection, but you have a syndrome which resembles a hemolytic uremic syndrome, we are referring it to as a typical hemolytic uremic syndrome. And in this situation, people investigated and found that there was deficiency of factor H. Similarly, homozygous FH mutations have been described in a condition called dense deposit disease, which is kind of the prototype of a group of disorders which are called the C3 glomerulopathies, in which basically the kidney tissue has a lot of surface bound C3b, which attracts, which basically starts the inflammatory cascade. A little more complexity to the factor H is a group of related proteins, which approximately 7 in number, which are called the factor H related proteins. They are functional competitors of factor H, so that when they are present in excess, the factor H becomes dysfunctional and is unable to dissociate the C3b from the surface of tissues. And factor H-related family gene deficiencies have been described in age-related macular degeneration, but more importantly for us, in IgA nephropathy, in lupus, and in atypical HUS. Now, a little importance to factor I, because if we know this, then we will discover more patients of ours who have deficiency as a driving factor for their disease. So basically, as I told you, CR2 needs factor 1 as a cofactor to bind its ligands, the split products of C3, and remove them from circulation. Now, factor I is also involved in the removal of C4b because it acts as a cofactor for the C4 binding protein, which is a complement regulator. And in the alternate pathway, factor H uses factor I in the first two parts of the pathway where factor H is responsible for removing surface-bound C3b. So not surprisingly, CFI mutations have been described and not too many. So the most of the patients, the slide basically says that most of the patients who have described not only have lupus or a vasculitis. This is important that some of these patients have ANCA-related vasculitis, but they also have a lot of infections. So the CFI mutations are associated with higher incidence of infections. So we experienced a patient with hypocomplementemic urticarial vasculitis as phenotype. She was 5 years old, born to non-consanguineous parents. She was symptomatic from the age of 3 years with a biopsy-proven urticarial vasculitis. And so we investigated her with a clinical exome, and we found that she had a large deletion on her CFI gene, and she had very, very low levels of C3 and C4, suggesting hyperactivation of the complement pathway. So I'm kind of trying to summarize the talk in these next two slides. So if you have to visualize, or improve diagnostics in complement-mediated disorders, then the most definitive diagnostic tests are what I have listed here. In the serum, to diagnose PNH, you can do a flow cytometry, which picks up deficiency of CD55 and or CD59. And there are no genetic tests because this is a somatic mutation. You can do in the serum CH50 or AH50, in which you have a defined number of RBCs. You take the serum of the patient, and at the end of the test, see how many of these RBCs are hemolyzed. So basically, you are testing the integrity of the complement classical pathway, or in another test of the alternate pathway. If you find that these are low, then you can backtrack and say which of the preceding molecules may be low. Most of the time, because we are clinicians and end users, we use only C3, C4 as markers of well-defined diseases like lupus. But nephrologists actually deal with more of these disorders where they have children with new onset nephritic disorders, where it is very important for them to know the etiology. And if we have good tests around us, if we have this array of serum tests, we will be probably able to give a more definitive diagnosis and hence better therapeutics to patients with autoimmune disorders. Now, what is important to know is that we might have to do whole exome sequencing in some patients where you have a hemolysis or a renal failure going on without thrombocytopenia. Remember that we have defined these as syndromes. Remember that there will be patients we will encounter who may have incomplete syndromes, and there we will have to have understanding of this complement system as well as a very high sense of alertness to decide whether we will be using exome sequencing, which could pick up disorders in CFH, CFI, or even C3 or ADAMTS13 and others, thrombomodulin and diacylglycerol kinase, etc. Now, I will end by discussing this slide a little. It is a complicated slide, but I have kind of, borrowed it for showing it to you, all of you, because it is very well made in the sense that it gives you a lot of idea. If you look at the colors of the circles, then it is telling you the drugs which are approved. The next circle tells you of the drugs which are likely to get approved. And going outwards, it gives you the idea that there are a lot of drugs which are in the pipeline of drug development, so that the next 5 to 10 years, a lot of these drugs which are in the outer gray circle may move inwards. What this circle also shows is the relative contribution of the current drug development system in different aspects of the complement pathway. So if you see that the larger chunks are for the alternate pathway, amplification loop, and the complement C3, the C5 and the C5A, C5A receptor, CR1, etc. On the right side, you can see that the complement therapeutics are taking the form of monoclonal antibodies, aptamers, proteins, small molecules, or peptides. And if you look at the panel on top, these could be either topical, oral, intravenous, subcutaneous, or intravitreal. So just taking a few minutes to talk about a few of these molecules. We are familiar with the names of eculizumab, ravulizumab. These are basically C5 inhibitors, monoclonal antibodies. They are approved for use in paroxysmal nocturnal hemoglobinuria. However, they are not the complete answer. So if you look at this molecule called tezidolumab, then what the Japanese found was that some of their patients with PNH were not responding to eculizumab and ravulizumab. And so they discovered that the C5a molecule of these patients had a mutation which rendered them unable to bind these developed monoclonal antibodies. So they developed another one called tezidolumab. So why I'm saying this is that as we understand the complexity of each molecule, the world has already understood the complexity, is already moving into, personalized development of drugs. And so it is nice to spend time understanding this area and waiting for these drugs to come to the Indian market. So for example, if you can look at this danicopan, which is in the alternate pathway amplification loop, then this is basically an inhibitor of factor D. So if you remember the alternate pathway, then factor D was responsible for the generation of C3 convertase. So it is, if you inhibit that, then if you still have a deficiency of CD55, which is the DAF, then you can still prevent the activation of the complement pathway. So these are strategies people are using, and it's a very exciting field. My understanding of this field is still not complete. So I would like to thank Dr. Kavita once again for spending her time and getting a lot of people together on Sunday for an academic exercise. Thank you, Dr. Kavita.
Thank you, Lisa ma'am. It was an excellent lecture. You took us to the entire, from the basic, the complement pathway. I'm sure the students have, really learned a lot, and they can go back and read and maybe like get back with more questions. Just from the students' perspective, when you get cases of lupus or, preaglobulinemia, etc. So, you got one more slide. Sorry. Yeah.
No. I'm just trying to see the chat box.
Yeah. Okay.
Yeah.
Chat box. Yeah. I'm just okay. So, how does C3 clear apoptotic bodies and immune complexes through the complement terminal pathway or C3A, C3AR receptor interaction on innate immune cells?
So this is, through the complement terminal pathway.
Terminal
The C3A, C3AR interaction is basically for building up, the adaptive arm. So if you have an apoptotic body, you have C1q on it, you have C1RS, which activates the C1q, then you have C3b, and this whole thing is opsonized through complement regular pathways, and it is cleared. The C3A is not part of this. The C3A interacts with its receptor and has other immune functions, which are again a huge area of, discovery.
So in lupus, we usually do C3 and C4 in which cases you feel that you showed those two cases of childhood lupus. So in cases in adults, we should go further for complement testing, like in which we should advise.
So we should, I think, in younger children,
Mhm.
and with a very strong family history. But I would not, advise it in strong family history because, again, strong family history has multiple inputs to development of autoimmunity, but especially in young children, and
Okay.
especially those who have infections recurrently.
Okay. What would be the therapeutic implications in younger patients of lupus with severely low C3, C4 levels who are in clinical remission?
You're trying to ask in
Varsha, maybe
clinical
you can
remission with
clarify. Yeah, Varsha, I think
persistently
it's
low.
Good morning, ma'am. Excellent
Hi.
lecture. Thank you. Yeah, so
Thank
ma'am, you mentioned younger patients of lupus, and there could be a discordance between their remission, the clinical remission, and the C3, C4 being extremely low in
posted.
such patients. So,
Yes,
in such
so this is
patients,
not, yes,
yes,
I got your answer. So this is
yes,
true not only in children, but also in adults.
yes, ma'am.
And so basically, as of now, we just watch them because they are in clinical remission.
So we go
But
clinical.
what we know as of now is that they are the ones who will flare again and
So,
again.
and also get recurrent infections, maybe, or we have to watch out for those also.
Yes, yes. So if they are having infections, you might sometimes add some plasma to their therapy, or even consider a hematopoietic stem cell transplantation. But that's
Okay.
not yet heard in India.
Mhm.
There's a lot of good
Okay.
stem cell transplantation going on in other diseases, in pediatric IEI, but we haven't heard that in lupus or lupus-like disease yet.
Any
Okay,
potential
ma'am.
role
Thank you.
of avacopan in lupus nephritis, especially C4 deficient lupus?
I haven't read that it has been tried, but uh, all of these are like kind of steroid sparing agents. They are working at the end of the complement cascade pathway. So if you have C4 deficiency, you have increased C5a, it probably will be tried, but it'll be because it has not been shown to be such a wonder drug in ANCA vasculitis. I am thinking that it may not be a wonder drug in lupus nephritis also.
A few words about when you get patients of angioedema. So what would be your approach? Like you would first just do C3, C4 and then do the,
So if you are looking at angioedema in the absence of any lupus, like a pure angioedema,
pure angioedema, yes.
I think I'm not the expert in this area, but what I have heard experts say is that C4 is the best test to do. So if you have very low C4, then you are actually looking at hereditary angioedema. And then you could probably go ahead and test the enzyme, or you could test the gene.
Many of the patients of lupus are in sepsis, so they have like the same thing, infection versus flare. So there, how do you interpret your C3, C4 levels?
So we are talking about using C3, C4 to decide whether there is infection or a flare.
Yeah, I mean, it confuses sometimes, you get.
Yeah, so if you have a lupus in remission who has an infection, basically the clinical picture will be clear. So there you might expect even the C3, C4 to be high. But if you are not sure, then C3, C4 low would suggest that there is a component of active lupus going on, but that does not exclude the presence of an infection. So you'll have to do the workup on both arms. And if you find that, yes, you've identified an infection also, and you have very low C3, C4, and some bit of nephritis or anything going on, then the challenge of how you treat this patient emerges, and that's a call lot of us take.
Any experience with targeted therapy with complements? Do you have done any trials or, your personal experience with any new drugs, phase 2 or something? Your personal...
No, sorry, we haven't had chance to work in this area.
Any more questions from the audience? Dr. Girish, you would like to ask anything? Dr. Samir? Yeah. Okay, I think we'll close. Thank you so much, ma'am. I know how busy you are to spare.
No, not at all. It's a pleasure.
Yeah, so
Thank you so much, ma'am. Thank you.
Thank
Thank
you.
you
Thank you,
very
Dr.
much.
Vaishnav.
Yeah, so thank you very much. Looking forward to interact with you again. And
Yes.
thank you everyone. Yeah. Hello. Yeah. So thank you everyone for being with us today for a Sunday session. And everybody's thanking Dr. Lisa ma'am for a nice lecture. Yeah. Happy Sunday to all of you. See you again for the next session. Yeah. Bye-bye.